Hi, Jack Cush here from EULAR 2024. I want to review with you the results of a presentation done today entitled EULAR Points to Consider on the use of anti-rheumatic drugs in reproduction, pregnancy, and lactation. This is a 2022 update, but at the end they said this is going to be the new recommendations, and it's a joint task force between EULAR. No, it's actually just a EULAR task force. So these will be EULAR recommendations presented by Professor Forger on behalf of the task force. Again, they updated this because they have new information about for some fertility issues, new information about use of or guidance for males who are on our drugs and can be involved in the conception process. So this was a multinational European cohort. I want to say that there was 20 plus people on the committee, many rheumatologists, a few methodologists. They did a literature search and came up with their consensus recommendations. The overarching principles were pretty much the expected. Patients should be counseled early and prior to pregnancy about pregnancy, that patients would who want to get pregnant should be aiming for remission and low disease activity prior to getting pregnant, that the risk of drug therapy to the mother and the child needs to be weighed so as to avoid both maternal and fetal risks going forward. And then the other important recommendation was there's a very strong recommendation that patients should be encouraged to breastfeed even though they may be on biologics. And that's really important. Okay, so let's get into what drugs you can use when you want to get pregnant or during pregnancy. There are many conventional DMARDs that are compatible with pregnancy: Plaquenil, chloroquine, sulfasalazine, azathioprine, 6-MP, cyclosporin, tacrolimus, and colchicine. That there are drugs that are teratogenic that need to be avoided. And the most strongest teratogen of all is mycophenolate, not Cytoxan, not methotrexate, not leflunomide, although those other ones are in this list. The teratogenic drugs are cyclophosphamide, methotrexate, and mycophenolate. They don't include leflunomide. I'll mention that later on. But mycophenolate is clearly the big teratogen here that you need to avoid. When it comes to nonsteroidals, prednisone and prednisolone, you can use these short-term therapy during pregnancy if needed to control disease activity, but they each have their own caveats that you need to take into account. For instance, with NSAIDs, they should only be used intermittently and before week 28, and probably only use the non-selective COX-2s. There are some issues about COX-2 specific drugs that may have more hazards associated with them. And they should also be discontinued in women who are having problems conceiving, that they could be interfering. Prednisone should be 5 milligrams or less and should be tapered whenever possible. Again, prednisone is one of those drugs that has significant maternal and also fetal risk outcomes, that including adverse pregnancy outcomes, that you need to know about. In women who have severe refractory RA and they're pregnant, what drugs can you use that are safe? Methylprednisolone, IVIG, CS DMARDs already mentioned, certain biologic DMARDs, sildenafil, and during the second and third trimester, you can use cyclophosphamide and mycophenolate. So that's kind of a new, interesting addition. With regard to biologic DMARDs, they certainly recommend monoclonal antibodies have the risk of placental transfer, fusion proteins much less so, and obviously FC-free molecules like certolizumab, none at all, and that should guide some of your use of the drugs. All TNF inhibitors can be used throughout pregnancy. They were quite a little soft on recommending certolizumab over all the other ones. That they said that certolizumab only really had to do with vaccination status, because it didn't affect the fetal vaccination in the newborn, whereas the biologics that they may cross the placenta will affect vaccination status. So again, the non-TNF biologics may be used effectively to control maternal disease. The ones that are okay and have supportive data would be abatacept, anakinra, canakinumab, ixekizumab, rituximab, sarilumab, secukinumab, tocilizumab, and ustekinumab. Very limited data, maybe not enough data, so some caution, and only use these drugs if other options don't exist. And this would include anifrolumab, eculizumab, guselkumab, mepolizumab, and risankizumab. Vaccination, non-live vaccines, inactive vaccines can be used at any time during pregnancy. You don't really need to worry about those. There's insufficient safety data about certain drugs during pregnancy, and I have leflunomide at the top of this list. And the new rule on leflunomide is worth noting. It used to be leflunomide, you had to wash them out and do the washout procedure with charcoal or whatever, cholestyramine, and then measure plasma levels of the metabolite. Now the rule is discontinue leflunomide for 3.5 months or 5 half-lives of the drug, and then you don't have to go through the whole washout. But there are a bunch of drugs that you really have to know there's not a lot of data about. This includes leflunomide, apremilast, avacopan, bosentan, a number of the JAK inhibitors, baricitinib, filgotinib, tofacitinib, upadacitinib, and then also voclosporin. So compatible with breastfeeding, a lot of drugs. Non-steroidals, even celecoxib, steroids, hydroxychloroquine, azathioprine, 6-MP, cyclosporin, tacrolimus, sulfasalazine, colchicine, and IVIG. Again, you don't worry about biologics and breastfeeding because there's very minimal transfer that of the biologic A into milk, and then if it's in milk, that gets into the newborn's system. So again, it's safe to be breastfeeding on biologics, TNF inhibitors, and non-TNF biologic drugs. There's a few drugs for which there's no data on breastfeeding, and maybe caution is advised and avoidance. This is bosentan, sildenafil, and methotrexate, for that matter, at doses below 25 milligrams per week. So I wasn't aware of that latter one. Drugs with limited or no data on breastfeeding: apremilast, avacopan, cytoxan, atoracoxib, iloprost, all the JAK inhibitors, leflunomide, mycophenolate, and voclosporin. So lastly, males. And what do you do with males? Basically, males can take any drug. It doesn't really matter, including the teratogens for females. Males can take any drug, with the only exception being cyclophosphamide. So I'm saying all biologics, IVIG, methotrexate, leflunomide, mycophenolate, sildenafil, sulfasalazine, colchicine, etc., and they can help in the making of a brand new baby. The ones that can't be used because of an issue of infertility is cyclophosphamide. So it is a cause of irreversible infertility. There are either no data or limited data, and consider alternatives for the following drugs. And they're basically all the new drugs: anifrolumab, apremilast, avacopan, bosentan, voclosporin, all the JAK inhibitors, eculizumab, guselkumab, risankizumab, and mepolizumab. So these guidelines have 5 overarching principles, 12 recommendations. There are 3 new recommendations about males. There are 2 new advisories on lactations and 4 new recommendations about drugs in pregnancy. So these are significant advances. They do complement the ACR guidelines on reproductive health. Both documents are going to be worth looking at. Tune in for more.